Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Lenalidomide and Rituximab for the initial treatment of patients with chronic lymphocytic leukemia, a multicenter clinical translational study from the CLL Research Consortium by Donnell James and colleagues. My name is Paul Barr. I am an assistant professor at the University of Rochester and medical director of the Clinical Trials Office in the James P. Wilmot Cancer Center in Rochester, New York. My oncologic specialty is lymphoid malignancies with a particular focus in CLL. In the article that accompanies this podcast, Dr. James and colleagues report on their multi-center trial testing the efficacy of lenalidomide and rituximab for first-line therapy in CLL. Lenalidomide is a second-generation immunomodulatory agent, or IMiD. While the mechanism of action is not completely defined, lenalidomide has demonstrated anti-angiogenic and direct anti-proliferative effects. Perhaps more importantly, it causes an overexpression of co-stimulatory molecules, repairing the humoral immune defect inherent to CLL. In vitro studies have also demonstrated its ability to enhance T-cell and natural killer cell cytolytic activity, facilitating synapse formation between the malignant B lymphocyte and normal T lymphocytes. Clinical studies with single-agent lenalidomide demonstrated responses in 32 to 47% of relapsed or refractory patients. However, tumor lysis syndrome and a tumor flare reaction mandated a lowering of the recommended dose for study, a slow dose escalation with additional precautionary measures. Lenalidomide's ability to promote immune effector cell function also appears to enhance rituximab-induced cell death. These data suggest that combining the IMiD with an anti-CD20 antibody might augment anti-tumor activity clinically. Consistent with this signal, lenalidomide with rituximab provided an overall response rate of 66% in relapsed refractory CLL patients, including 12% complete responses and 12% nodular partial remissions. The time to treatment failure was 17 months. Further, only one event of grade 3 tumor lysis was observed when a maximum lenalidomide dose of 10 milligrams was used. Given the need for non-chemotherapy-containing regimens in the predominantly elderly CLL population and the potential for synergistic efficacy between lenalidomide and rituximab, James and colleagues investigated the combination as first-line therapy in two parallel age-specific strata, patients less than 65 years and those 65 years or older. Patients in this study initiated lenalidomide at 2.5 milligrams daily, escalating to 5 and ultimately 10 milligrams daily during subsequent 28-day cycles. Rituximab was administered during cycle 2, given in dose-dense fashion, then once during the remaining 5 cycles. Prophylactic allopurinol, hydration, and tumor lysis monitoring were employed. The primary objective was to determine the CR rate for each cohort. Prior studies investigating single-agent lenalidomide in previous untreated patients demonstrated response rates of 56 to 65%, including 0 to 10% complete responses when administered as initial therapy. A 2-year progression-free survival of 60 to 89% was observed in these patients who received a median of 18 to 27 cycles of therapy. In the current study, an overall response rate and complete response rate of 95% and 20% respectively, as well as a median progression-free survival of 19 months, were achieved in the younger group, having a median age of 57 years. In the older cohort, having a median age of 70 years, a lower overall response rate and complete remission rate of 79% and 10% respectively was observed. However, the median progression-free survival of 20 months was no different. Consistent with the results in relapsed patients, the addition of rituximab to lenalidomide appears to improve the rate of overall and complete responses, supporting the potential of in vivo synergy. Correlative studies demonstrated that lenalidomide only reduced the expression level of CD20 modestly, consistent with the high response rates observed. In addition, the 67% and 89% response rates in patients with deletion of 17p and 11q respectively compare favorably with chemoimmunotherapy combinations. The modest durability of response with the combination may be in part related to the number of cycles administered, which was limited to 7 in the current trial. Treatment was generally well tolerated. Neutropenia occurred in 3/4 of patients and was largely grade 3 or 4 in severity. However, infectious complications were infrequent. Tumor flare reaction also occurred in 3/4 of patients, but these events were grade 1 or 2 in all but one patient. 2 episodes of pulmonary emboli prompted aspirin prophylaxis. Following this, no further thromboses occurred. There were no second malignancies, a concern raised in large randomized multiple myeloma studies. However, follow-up was short in the current study. A longer period of observation will be needed to better understand the risk in CLL. Importantly, tumor lysis syndrome was not limiting in this study. How does this study fit into the body of literature, and should lenalidomide or rituximab be considered as an option for upfront therapy in CLL? While we do not have randomized studies to guide us, the progression-free survival from the current study appears inferior to that observed with chemotherapy-containing regimens, such as the combination of fludarabine, cyclophosphamide, and rituximab, or the combination of bendamustine and rituximab. As such, lenalidomide and rituximab may not be ideal for younger, fitter patients. Whether a longer treatment period would prolong the remission duration is unclear. Lenalidomide and rituximab was well tolerated, and the toxicity was no worse in the elderly cohort. While the response duration suggests the combination might compare favorably with chlorambucil and anti-CD20 antibody combinations, a recent phase 3 trial comparing lenalidomide with chlorambucil as upfront therapy in CLL was closed due to a higher number of deaths on the lenalidomide arm. As such, current use of first-line lenalidomide and rituximab cannot be recommended. Attempting to build upon the IMiD antibody combination, lenalidomide and rituximab, may represent a chemotherapy-free platform for incorporation of novel agents targeting B-cell receptor signaling, particularly for CLL patients with high-risk features. Ongoing studies are evaluating the Bruton's tyrosine kinase inhibitor, ibrutinib, as well as the PI3K delta inhibitor, idelalisib, in combination with lenalidomide and rituximab in relapsed or refractory patients. In conclusion, this study demonstrates high overall response rates for lenalidomide and rituximab in the upfront setting for CLL patients, consistent with previous laboratory data. However, a fairly modest progression-free survival was achieved with the limited duration of therapy. Ongoing investigations will inform us on whether the combination can be improved further with the addition of novel small molecule inhibitors, providing chemotherapy-free therapeutic options for patients with CLL. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.